I'll quickly mention my conflicts of interest. As Jenny said, I've been involved in the development of an algorithm that's used in the Vitalograph cough monitor, but the royalties all go to my engineer in my hospital. I don't receive any money myself, but I do consultancy work for pharmaceutical companies developing cough drugs. So what I plan to do is cover 4 main areas. Talk about the relevance of cough frequency data, mention some of the challenges in measuring cough and analysing cough, then talk mostly about how cough frequency has been applied in studies in recent years, and then finish up by talking a little bit about what some of the future applications might be. So to start with, what's the relevance of cough frequency data? Why would we want to measure these things? So I guess a good starting place is what might be the purpose of measuring cough. And I think that boils down to 3 main areas really. First of all, the thing that often comes to mind first is that we want to test therapies. And that can be about understanding whether existing cough treatments work, but also about developing new therapies that might be more effective. Also, you may want to measure cough because it could be a side effect of a particular therapy. A second purpose is around understanding mechanisms, so what's driving cough in different diseases. And thirdly, we may want to use cough as a way of measuring how well a disease is controlled, or even to detect exacerbations of disease. So you might argue that we just need to ask somebody how bad their cough is, and that is certainly one approach, and a patient's perception of how severe their cough is definitely important. It's no good reducing the amount somebody coughs if it's not sufficient for them to actually feel better. But one of the issues with these sort of subjective measures is that they are a measure of multiple things, some of them about the cough and some of them about other factors that may not be so important. So when we look at patients' ways of scoring cough severity, we do see moderate correlations with the number of times people cough. Cough severity probably also relates to the patterns of coughing, and I'll come back to that towards the end of the talk. So people who cough in long fits or bouts of coughing probably rate that as more severe because it's particularly unpleasant. The intensity of the cough, so how violent or harsh the cough is probably important too, as is the sensations of an urge to cough, often as a result of feelings of irritation in the throat. Then there are also complications of coughing that may affect some patients and not others, such as coughing so much that you vomit or having problems with urinary incontinence. And all of these things feed into disruption in terms of how cough affects people's quality of life, which also can be collected using specially developed questionnaires. But then there are other factors that may influence how cough severity is scored, and so differences in people's lifestyle may mean that coughing impacts more on some rather than others. Some people may be better than others at remembering and recalling just how often they've coughed in a day. Mood may be a factor as well. Chronic coughing is frequently associated with poor mood and depression, and that may influence how people score their cough. Equally, some people will just pay more attention, be more vigilant to the amount they're coughing, and therefore may rate their coughs on any kind of a severity scale more accurately than others. The other thing to remember if we're interested in developing drugs is that drugs that act in the central nervous system may actually affect patients' moods and their vigilance as well, and therefore impact upon the scores in a different way than just by improving cough. And so hence there's been quite a focus on developing an objective measure of cough, and what I'm going to focus this talk on is the measurement of cough frequency, so measuring the number of coughs over a period of time in our patients. So this is not a new idea. It was first published back in the 1960s, and this is a picture from a publication in Thorax showing an inpatient with respiratory disease, and his cough was being monitored through this microphone that you can see attached to the wall. And he's wearing headphones because his only entertainment is being able to listen to the radio in the corner. He's not allowed to talk to anybody because that'll interfere with the cough monitoring. And this connected through a hole in the wall to a not so sophisticated sound monitoring system, where we've got a couple of reel-to-reel tape recorders and a chiming clock so that they knew what time it was. So despite the relatively rudimentary nature of this equipment, it was entirely possible to show the effect of doses of codeine over a 22-hour period compared to the syrup it was in. And so if we have a look at this graph, this is for an individual patient, you can see the cumulative number of coughs is plotted up the y-axis. We've got time from 6 p.m. in the evening on the first day through to 4 o'clock on the following day, and then the arrows at the bottom are showing you the dosing periods of the codeine. And here in these graphs, we can see that there's up to accumulation of almost 1,000 coughs over this period in this particular patient. And no treatment and 2 different sorts of syrup really didn't have any effect in terms of the cough. However, when the patient was given codeine syrup, you can see the number of coughs dropped immensely. It was down to more like 300. Now, I'm not meaning to give you the impression that codeine is a really good cough treatment here. So the important thing to know is in this study, for any of the clinical people listening, the patient was given 2.5 grams of codeine in 24 hours. A typical dose these days is more like 30 to 60 milligrams. And so this was a very big dose, and maybe his eyes are shut because he was actually sleepy most of the time. But nonetheless, this study proved the principle that you can measure the amount of coughing over a time period in a patient, and you can show the effect of treatment by counting the number of coughs. So how exactly were they counting coughs in that study, and how do we generally count coughs in the studies that we've been doing in recent years? Well, a typical acoustic waveform is shown here. This is in the time domain, so we've got the amplitude of the sound plotted by the time in seconds. And you can see that coughs are over very quickly. This particular one is about 400 milliseconds, that's all. And an absolutely typical cough consists of an explosive phase followed by a decrease in the sound during an intermediate phase, although this can be noisy in coughs that are accompanied by sputum in the airways, followed by a voiced phase at the end, which is, in terms of the waveform, is very regular and much more like speech compared to the explosive phase, which is chaotic and noise-like. And these sounds are produced by the vocal cords moving in a characteristic way and interrupting the flow from the airways following a contraction of the expiratory muscles. And hopefully you'll be able to hear this. I'll see if I can play you this video producing a cough sound and showing you how the larynx moves to produce those sounds. We'll do that once more. It's often tricky to hear the voice sound, but believe me, it's nearly always there. And so if we go back to our chap in 1964 being monitored in his bed, what's being counted here is those explosive phases. And so what they're saying is that without any treatment, somewhere between 700 and 1,000 of those are occurring within a day. Now, typically coughs don't occur on their own. They usually occur in bouts or episodes or epochs. There's lots of terminologies used, so you'll generally get clustering of these explosive sounds. And so if I play this waveform to you that's showing some coughing over a period of 5 seconds, hopefully we'll all agree on the number of coughs that are there. Oops. So although you can see quite a few spikes here, the explosive sounds are there, 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 and there. These additional spikes in between are just quite loud voice sounds. So that's 5 explosive sounds at all. And so this is, generally speaking, how most people would quantify coughing. And this has been shown to correlate slightly better than other methods of quantifying coughing in terms of relationships with cough severity scores and quality of life. So using cough monitoring systems, we've been able to understand for the first time really just how much people cough when they've got different respiratory diseases. So this graph is just some data collected from across a bunch of different studies done over many years in our group, where we're plotting the number of times that they've coughed in a day, so 24-hour cough frequency up the y-axis. The important thing to note here is this is a logarithmic scale, so we're going up tenfold from 1 to 10 to 100 as we go up this y-axis. And here you can see a group of 51 healthy controls, and you might imagine that healthy people don't cough, but they do. And so typically they'll cough about 10 to 15 times in a day, usually during waking hours, but they'll often score their cough at 0 because they've often coughed so infrequently that they've not really even noticed. At the opposite end of the spectrum, we've got some data here from a group of 54 otherwise healthy volunteers who've got a cold and are complaining of the cough with a cold. And you can see that this is more than tenfold higher, averaging around 20 coughs per hour. As I say, this is a 24-hour period, but most of those coughs will be during waking hours. But you can see at the top end, some people are coughing 100 times per hour. So this really can be very frequent. And so if you look at patients that we see in our cough clinics complaining of chronic cough, they actually cough remarkably similar in terms of their frequency to patients with coughs and colds. It's just that in our chronic cough patients, this is going on for months and years, whereas an acute cough will usually settle down within 3 weeks. How about the other diseases we've got here? Well, healthy smokers, perhaps not surprisingly, cough more than healthy volunteers. And then you can see there's a gradual increase from patients with asthma, COPD. I'll talk a bit more about these shortly. Also, patients with IPF are coughing quite frequently, as are patients with lung cancer, although this is a selected group complaining of cough. But you can see for all of these groups, there's a great deal of variability. The whiskers on these box and whisker plots represent the full range, and so you can see there's a lot of overlap between different conditions and a great deal of heterogeneity in terms of how much individual patients are being bothered by a cough. So what are the challenges in obtaining data like this and getting an accurate measurement of just how frequently somebody is coughing? So if we use this timeline to represent our 24-hour recording, with it divided up into 1-hour chunks from 9 AM in the morning to 9 AM the following morning, which is often what these recordings look like. So waking hours followed by a period of sleep and then more waking hours. Then what you see is that cough frequency is greatest during the day, with these red lines representing individual cough events, but much less frequent, generally speaking, at night. And as a rule, when people are asleep, sleep is pretty good at stopping people from coughing. And of course, what we want to detect is these events, and what we want to ignore is sounds going on in between times, such as speech. Speech is one of the commonest things that we pick up in these recordings, but also if there is an air-coupled microphone used, you're going to pick up an infinite number of different sounds from the patient's environment as well. And so it's quite challenging picking up these cough sounds from everything else that's going on in a person's day in terms of the sounds that are there. So I'll tell you a bit about the Vitalograph system, which, as I said at the beginning, we helped develop. So we have a device that makes a 24-hour recording typically, although it is possible to do longer than that, followed by an algorithm, which is essentially a sound filtering algorithm that removes the vast majority of non-cough sounds and silence, and leaves us with a file which is much shorter, typically about somewhere between 1 and 2 hours long, which then can be listened to and the waveforms visualized, just like I showed you before, using trained cough analysts, and they can count and electronically tag the positions of the coughs in that compressed recording. It's then possible to reconstruct those locations in the original recording to give you a measure of how much coughing and when it occurred. So to try and give you an idea of how much data we're talking about, if this pie chart is representing all the sounds we've got in a recording, even in somebody who coughs a great deal, the amount of cough is relatively small compared to everything else. And so what our filtering algorithm seeks to do is to remove the non-cough sounds, remove the silence, and we're left with a recording which is a mixture of cough and some cough-like sounds that is then manually listened to. And to give you an idea of how that software performs, I've just got a rather busy slide here with some of our validation data. So what this is showing you is how many coughs are present in the 24-hour recording prior to compression with the software, how many coughs are missed because the software removes them, and therefore what sensitivity that gives you, and then the length of the recording at the end, which is a sort of a measure of specificity. So this is how long the file is that has to be listened to. It's important to test cough algorithms across a range of different diseases as well, because coughs do vary somewhat. There may be more or less sputum or wheeze in the cough. The cough may be altered by differences in lung volumes. And you can also see the frequency of coughing that occurs varies a great deal, just as I showed you in the previous graph. And therefore, picking out cough from non-cough sounds is more challenging in those recordings with very few coughs, such as healthy volunteers or asthma patients. But I think what you can see overall here is that we're missing very few coughs by using this algorithm, and therefore maintaining a very high level of sensitivity. And that's the case even in the worst case scenarios. You can see our lowest sensitivity here is down to 80% in healthy volunteers, but of course that's because there's a relatively small number of coughs here, and so if you miss one, it represents quite a large percentage. The other important component of the system that we use is the accuracy of the cough counting done by cough analysts. And both in my academic group and at Vitalograph, these folks are trained in how to count cough in order to get good agreement. This is some data that we presented at the RS a few years ago now, showing agreement between two different cough counters from the Vitalograph team, and showing what they counted across cough recordings with a range of, as you can see, the highest number of coughs here is nearly 10,000 in a 24-hour period, plotted against the difference between the two cough counts. So this is a Bland-Ullmann plot, often used for assessing agreement between different measures. And essentially what this shows is the mean difference between two counters over a 24-hour period is less than one cough. So cough counting really can be very accurate when people are trained. If anybody's interested in interclass correlation coefficients, that's extremely high as well. These tend to get saturated and so don't really terribly well represent the agreement that you see between trained analysts. So hopefully I've convinced you that our algorithm removes very little in the way of cough, and that the cough analysis is very accurate for our system. But of course, it's a semi-automated system that we're using. It's a mixture of an algorithm and manual counting. What would be the most efficient way to count coughs would be to have a fully automated system. However, automated systems are always going to be less accurate than the gold standard, which is really manual cough counting. Now, obviously, I have a conflict of interest in that I helped develop the Vitalograph cough monitoring system, so I'm not going to review other systems. But what I thought it might be useful to do was to share a few tips about how I look at more automated systems and try and assess whether I think they're going to be clinically useful or not. So typically when we're assessing cough algorithms and all sorts of other tests as well, you use this perhaps appropriately named confusion matrix, where we're looking at what our true findings are in terms of positives and negatives. So for cough detection, this is the number of true coughs that are detected by an algorithm versus the number of false positives, so sounds that are not cough but are being detected by the algorithm as cough. And then also important to look at is the number of false negatives, so how many coughs is an algorithm missing, but how many true negatives are there and how accurately is the algorithm recognizing non-cough sounds. So as I say, just a few tips. So first of all, you'll often see sensitivity and specificity quoted for cough detection systems. And it's important to note that because you get very large amounts of non-cough, that's easy to accurately detect. And so very high specificity is often not a useful measure of these systems. It's also very difficult to quantify. It's easy to say whether a cough is there and detected or not, but how do you quantify a non-cough sound is an important question when looking at these sorts of results. So I would argue what's most important when you're trying to think about whether a cough monitoring system is going to be clinically useful is actually the balance between the true positives and the false positives, because this can really give you the wrong impression if you're not careful and if these are not well balanced. Where there's a relatively small number of coughs in a particular disease group, a small number of false positives really can outweigh the true positives that are there. Other tips, I'd be aware of pooled data. So it's very common for data to be pulled together into a big data set to look at cough monitoring performance, and then a sensitivity and a specificity quoted. But what that doesn't tell you is what the variability is in the individual patients. As I showed you for our performance monitoring, we gave an average and a range for the sensitivity and for the efficiency of the compression. Because in some patients, it may be that the monitoring is performing well, but in other individuals, it may be that it's very inaccurate. It's also important to be aware of agreement data, like I showed you in the Bland-Altman plot. So unlike the confusion matrix, which tells you exactly which events are being detected correctly and incorrectly, you can look at cough algorithms by plotting a manual count against an automated count in a Bland-Altman plot, but you don't know if the same events are being identified. And this can cause problems with compounded errors. I'll try and explain this as best I can. So, for example, we might have a cough recording that's got 500 coughs in it altogether. When we count manually the 24-hour recording without any automation. And perhaps we have an algorithm that's capable of detecting correctly 400 of those coughs. So the true positives are 400. So we're missing 100 coughs, but maybe the false positives are similar to the number of coughs we're missing. So maybe there are 99 with 100 false negatives. And as I suggested to you, that the number of true negatives is going to be very large, and it'll depend how it's quantified as to what that number looks like. But in a situation like this, the agreement data may suggest 499 compared to 500 coughs, which looks like it's very similar. However, there's an inaccuracy there because these are not actually the coughs that are being detected. So we're falsely recognizing almost 100 coughs and we're missing another 100 coughs. So there's an error of 200 coughs here, which could cause you problems with trying to detect change. So how has cough frequency measurement been applied in recent years? There's two really main sections to this bit of the talk. I'm going to talk about mechanisms and about drug detection. So I'll very quickly just cover how we think the cough reflex works, because that's important for understanding how cough monitoring might give us insights into mechanisms. And what we know, largely from animal models, is that stimuli in the airway send action potentials up the vagus nerve. These synapse in the brain and cause sensations such as the urge to cough and a feeling of throat irritation. And if the stimulus is strong enough, it will evoke actual coughing. So in disease, we get excessive coughing, so more than just that protective airway reflex. And there's three main ways that that can occur. First of all, there may be excessive stimulation in the airway, and that could be due to irritant chemicals that are being released or inhaled, or mucus in the airways. Secondary, those vagal afferent fibers may be altered and hyperexcitable. And then finally, there might be a hyperexcitability of the central nervous system. Equally, all three of these processes could be going on in individual patients. So how can we get some insights into what's going on using cough monitoring? If I start with COPD, this is a study we did quite a few years ago now, looking at a group of patients with COPD, some of whom were smokers, some of whom were ex-smokers, and we compared them to some healthy smokers and some healthy non-smokers. Again, we've got a log scale up the side. And so actually this small difference between the ex-smokers and current smokers is a doubling in the average amount of coughing. So clearly whether you smoke or not makes a big difference to how much you cough if you've got COPD. But also if you don't have COPD, with the healthy smokers coughing more than the non-smokers. And you can use cough frequency data like that to look at a whole series of features in patients and to see what things statistically predict how much people are coughing. And if we look at these factors one at a time, so in univariate models, we can see in this study that sex, age, lung function didn't at all predict the amount of coughing. The amount of coughing induced by capsaicin, which is chili pepper extract, which is a way of measuring the cough reflex and giving us an indication as to whether those pathways are hyperexcitable, was significant when analysed on its own, as was the amount of sputum patients expectorated, as was their current smoking and how much smoking they've done in the past. So very much suggesting that sputum and cigarette smoking behaviour, past and present, are important here. And you can put this into a multivariate model because some of those things may be correlated with one another. And actually what you find when you do that is that the hypersensitivity of the nerves suggested by the capsaicin testing is no longer significant. And that's probably because that's related to previous past smoking history and the amount of sputum expectorated. We also were able to induce sputum in some of these patients, and that allowed us to see that the amount of neutrophils in the airways are important too. So I can modify my diagram in patients with COPD and say that the amount of cigarettes they've smoked in the past and currently is important in driving cough, as is neutrophil in their sputums, as is mucus. And as far as we can tell from that study, sensitivity of the airway nerves may be secondary to these, but doesn't independently predict coughing. In contrast, we've done some work in asthma, and this is a similar sort of study with a group of patients with moderately severe asthma. Now, one of the things that people always think about asthma is that it causes cough at night. And as you can see from the graph here on the left, which is actually in time spent coughing, these patients do cough at night, but they cough a heck of a lot more than they do during the day. And therefore, nocturnal cough in terms of monitoring cough does not particularly seem to be a feature of asthma. And none of the features of asthma that we measured were important. There was a weak correlation with age, but apart from that, gender, FEV1, measures of exhaled nitric oxide, methacholine responses, how long they'd had asthma and how much inhaled corticosteroid they were on, didn't seem to have any effect at all on the frequency of coughing. We went on to do some more studies, and I've got a couple of studies to show you done by Imran Satya when he was my PhD student, to try and understand what it was then that might drive coughing and asthma. And in this study, Imran gave patients methacholine in order to change their lung function, and then looked at how much coughing was evoked by capsaicin. And you can see as we bronchoconstricted a group of asthmatic patients, their cough responses to capsaicin increased, suggesting a sensitization of cough reflex. We also saw more spontaneous coughing after the methacholine challenge, which settled when we gave them bronchodilators and reversed them. So an indication that in an individual patient, changing airway caliber could be important. Imran also looked at cough responses to a more real-world exposure, and we did an allergen challenge study collaborating with Paul Byrne and Gail Gavreau over at McMaster. And this was a group of patients where we looked at allergen challenge compared to diluent, and here you can see the changes in lung function in terms of the classic early and late responses. If you monitor how much those patients cough, you do see coughing, and a fair amount during the early response, as you can see, with it coming out about 10 coughs up here compared to the diluent. And again, the exaggeration in the coughing is occurring during the episodes of bronchoconstriction and settles as those resolve. So for our model of what's driving cough in asthma, I think we can say that we've got evidence that one of the main issues here is bronchoconstriction, and that's true whether it's artificially induced using methacholine or whether it's in response to allergens that patients are known to be exposed to. So next up, we'll talk a bit about how measuring cough frequency has, in my opinion, helped us really develop new treatments to treat cough. And you can use cough frequency measurements to try and understand whether drugs that have been around for a long time make a difference. And Alan Maurice did this study back in 2007 now, suggesting that very small doses, just 5 milligrams of slow-release morphine sulfate therapy given twice a day, could improve patients who've got refractory chronic cough. So these are patients in whom the cough isn't responding to treatment of underlying asthma, nasal disease and reflux, and therefore in whom are still coughing a great deal. And as you can see here, using this cough score, he had a statistically significant effect of this treatment compared to a placebo. More recently, we went on to have a look at this using cough monitoring. Now, it's important to say that this group of patients were selected because they'd had a response to morphine in the clinic. So these are probably the best responders. But we did a double-blind randomized crossover trial with just over 20 patients, and we're able to show that morphine compared to placebo in this group, again at the 5 milligram dose, produced a 71% reduction over placebo. And this is one of the real strengths of cough monitoring in developing drugs. Treating people for short periods of time using crossover trials, cough monitoring is very powerful. You don't need many patients in order to detect treatment effects. And we showed this classically in the first study that we did with gefapixant, the first of the P2X3 antagonists to be tested in patients in chronic cough. And we published this back in the Lancet in 2015, showing that 2 weeks of treatment with this treatment on the right-hand side compared to placebo on the left, dropped cough frequency on average by about 75%. And since then, we've gone on to do a series of other studies, again using the Vitalograph cough monitor and cough frequency of the primary endpoint. And this is just one of the phase 3 studies published last year, again in the Lancet, showing that actually you get quite similar drops in cough frequency with the lower doses of gefapixant. So this is a geometric mean ratio. So down to 0.4 would be a drop of 60%. So this is just over 60% drop. So actually similar to what we saw in the original proof of concept study. However, in these later studies, you can also see that we're getting much bigger placebo effects than we got originally. So what other new drugs are we seeing more recently that seem to be having an effect in cough? Well, I mentioned in my previous slide that patients with IPF cough quite a bit. Those are the lung cancer patients with cough, those that are approaching refractory chronic cough frequencies the most. And this isn't fully published yet, but has been presented at ERS last year and then also at BTS, that nalbuphine, an opioid, but a kappa agonist, so slightly different from morphine, when given an escalating dose manner over a 3-week period, produced a 77% drop in cough frequency from baseline compared to 25% placebo, again in one of these small proof of concept studies using just 26 patients. And so hopefully there will be more studies using this therapy, confirming this and understanding the different doses. But there's no question that pulmonary fibrosis has a definite need for effective treatments for cough. It's frequent coughing that makes people's lives miserable. But of course, sometimes our new treatments don't work. We did a couple of studies. This is the second one we did with a TRPV1 antagonist that didn't get a name, but it was called Zen DO501 at the time. This time I've just shown the cough frequency plotted hour by hour, so you can see the daytime amount of coughing here followed by night in the beginning of the day. And you can see that even though this was a very potent drug for cough blocking this mechanism, it was very good at blocking capsaicin-evoked cough, that particular mechanism did not seem to be important in spontaneous cough frequency, and there was no difference between drug and placebo in this study. So where might we be going with cough monitoring in the future? I thought I'd make a few suggestions about other endpoints apart from cough frequency and how they might be applied. So something that I get asked about and gets discussed a lot and is quite a controversial area is the intensity of coughing. And there isn't really an agreed definition of cough intensity, but what I would say is that it's important to be clear that the intensity of the cough sound and the intensity to patients are not always correlated with one another and are not the same thing. We did a study a few years ago with John Moxham's group where we looked at the energy in the cough sounds and how it was affected by 2 different things. So first of all, the amount of effort that the subjects put into coughing, and these were healthy volunteers coughing voluntarily. But the other thing that makes a difference is how big a breath they take in before they cough. And so we controlled that and got them to cough from volumes of 10, 30, 60 and 90% of their own forced vital capacity. And so what I think you can see here is that as you take bigger breaths in and you put in more effort, you see increases in the energy in the sound waveform. And that's because you're creating greater flows, which is turned into sound energy, which makes sense. So at the same time, we measured EMG, which is the electrical activity and the neural drive to cough in the expiratory muscles. And we measured it across a series of these. These are the ones in the lateral chest wall. And again, this is the area under the curve. But I think what you can see here is that from 30, 60 and 90% of vital capacity, the muscular activity, the neural drive to the muscles is actually remarkably similar irrespective of volume, but increases with increasing effort. However, when healthy volunteers were coughing at just 10%, so below their residual volume, it was very difficult to do and it required a lot more muscular effort. You can try this yourself. If you breathe out and then try and cough, it's quite uncomfortable and arguably quite an intense experience, although the sound that produced is quite quiet and muscular activity is quite high. So I think it's possible, and there may be interesting information in the intensity of the cough sounds, but it's important to remember that they don't necessarily reflect the intensity of the experience for patients. Something else that I think is interesting and may contain important mechanistic information is the temporal patterns of coughing. And what I mean by that is how the coughs cluster over a 24-hour period. So to go back to our timelines here, I've got two different patients. First of all, patient A, who's coughing 60 times. And you can see they're coughing typically in couplets, so two coughs together quite frequently, not a lot at night. However, I can have another patient, patient B, who also coughs 60 times, so has the exact same cough frequency, but the clustering of the cough is very different. So they're coughing in long bouts with gaps in between. And anecdotally, in our experience, patients like this may complain that their cough is more severe than patient A. And so the question is, how can we capture this and how can we look at whether those different patterns are important? So as I mentioned before, typically we count the explosive cough sounds, but what we can do instead is merge these into cough bouts. Classically, this has been done using 2 seconds as the definition. And so in that case, this series of 5 coughs would be lumped together into a single bout or epoch or episode, whatever terminology you want to use. In which case you're able to quantify the number of bouts that are occurring, but also the bout length, and that might contain interesting information. Why do I say that? Well, we performed a study, and I forgot to put the reference on, but this is published now. So Huda Badri, who did her PhD with me, did a study looking at lisagabaran, treatment for acid and non-acid reflux originally, which is a GABA B agonist. And we looked at this in one of these small proof of concept studies in about 20 patients with chronic cough. And what was very interesting is that when we looked at the reduction of cough for placebo compared to lisagabaran over a 2-week treatment period, looking at the explosive cough sounds, we saw a 26% reduction, which didn't quite reach statistical significance. However, when we looked at bouts of coughing and lumped the coughs together, we got a slightly larger reduction, which was statistically significant, suggesting that bouts of coughing may be what this drug was influencing more than the number of individual cough sounds. Finally, I was just going to mention the possibility of using cough monitoring in clinical practice, which I think could be very interesting and important in future. So why might we want to do this? Well, in an individual patient, we might want to understand whether a particular treatment has made a difference on the number of times they cough. We might use it a way of monitoring their disease activity, and it could be a way of predicting exacerbations in patients with asthma and COPD. I suggest that because, as you can see on the right-hand side here, we've got some data that Paul Marsden collected during his PhD, looking at the relationships between cough frequency and disease control by genocategory. And you can see you get these statistically significant differences in the amount of patients as you move from controlled to partly controlled to uncontrolled. So this could be a way of monitoring asthma control alongside things like FEV1 and sputum inflammation. In terms of, oh, sorry, I'll just go back one to finish that. So in terms of what cough monitoring clinical practice might require, so the current devices that we have and methods that we have are quite time consuming, as the most accurate ones are not fully automated and need some manual input. So a fully automated system would really be needed to be able to do this quickly, cheaply, and in a way that's applicable to clinical practice. Something that we do need to understand, though, is how accurate a fully automated system would need to be, and we'd need to be confident that that level of accuracy was at the individual patient level, and so that we wouldn't be given misinformation about the amount of coughing and whether it's changed at an individual patient level. Another question that I don't think we know the answer to as yet is that if we're going to want to monitor treatments in clinical practice or understand disease activity or even try and predict exacerbations, do we need to be able to monitor for longer periods than 24 hours? All the data I've shown you from our recent work has all been in 24-hour recordings, and those have certainly been very effective for understanding mechanisms and testing treatments. To understand more subtle changes, maybe longer treatment periods might be useful. We need to collect data over longer periods in order to understand that. So finally, to conclude, I'd argue that monitoring cough frequency really has changed the standards by which we're evaluating cough treatments now, and has really allowed us to discover some new therapies. It's also given us indications of what the pathophysiological processes might be that are leading to coughing. In COPD, I'd say it confirms our intuitions that a lot of coughing is relating to bringing up phlegm and smoking. In asthma, I think it challenges the dogma that people cough more at night, and it's much more related to changes in airway caliber than anything else, as far as we can tell. At the moment, this is just what we've found from basic cough counting. I think new parameters have a lot of potential to allow us to understand more about disease processes and mechanisms. And I do think that in future, cough monitoring could be valuable in clinical practice, but there are some technical challenges to overcome to be able to really apply that. And there are some studies to be done to understand just how accurate those systems would need to be useful, and just how we should apply them in clinical practice. So with that, I will just quickly acknowledge lots of folks in my team and my collaborators and the various funding bodies that have helped